Thanks, Mr. Chairman. Thanks for the organizing committee for their kind invitation for me to share in this honorable conference for hypertension. My case today is entitled Rare is Present. My patient is a female patient, 51 years old, diabetic, uncontrolled hypertension, obese without previous history suggesting any cardiac disease. No use of oral contraceptives, non-steroidal, corticosteroids, licorice, or other herbal supplements, and no illicit drug abuse. On examination, her weight was around 105 kg, height around 173 cm, body mass index 35.1, blood pressure around 190/110, heart rate 87 beats per minute regular, chest and heart non-significant findings, ECG showed criteria of LVH. Her echo showed concentric LVH with good systolic function. Ejection fraction was around 72% by M mode. She had LV diastolic dysfunction grade 1, and here is the apical four-chamber view showing concentric LVH. According to the recent ESC guidelines for management of hypertension, we risk stratified the patient. Our patient was grade 3 hypertension. She was diabetic, had hypertensive LVH on echocardiography, thus she fulfilled to be high risk in the high risk group. Her lab investigation shows creatinine around 1.2 mg per deciliter, uric acid was 6.8 mg per deciliter, serum sodium around 135, and serum potassium around 2.3 millimole per liter, otherwise normal lab findings. The recent ECG guidelines recommend that patients with grade 3 hypertension above 180/110 should undergo lifestyle recommendations and start immediate drug therapy in all patients, aiming for blood pressure control within 3 months. It is recommended to initiate antihypertensive therapy with 2 drug combination, preferably in single pill combination. And if blood pressure not controlled with 2 drug combination, treatment should be increased to a 3 drug combination, usually RAS blocker with calcium channel blocker and thiazide. However, if blood pressure is still uncontrolled with 3 drug combination, treatment should be upgraded by adding spironolactone, amiloride, a beta blocker, or an alpha blocker. Thus, we initiated antihypertensive therapy in this patient in accordance with the ECC guidance as follows. She received amlodipine 10 mg plus valsartan 160 mg plus hydrochlorothiazide 25 mg in a single pill combination. During follow-up visits, her blood pressure remained uncontrolled above 170/100 despite patient compliance to therapy and adherence to lifestyle recommendations, and the readings were confirmed by home blood pressure monitoring. We added carvedilol 25 mg tablet twice daily in addition to the previous combination. However, blood pressure also remained uncontrolled again. Thus, we started to investigate this case as a case of resistant hypertension. On reviewing the laboratory investigations of the patient, we noticed hypokalemia, and that was the first clue for the diagnosis. We decided to investigate for causes of secondary hypertension, especially those associated with hypokalemia. We stopped all antihypertensives and shifted to verapamil 240 mg sustained release tablet twice daily for 2 weeks. Then, we investigated plasma aldosterone ratio that came to be 37. For confirmation of our diagnosis, we performed acute saline infusion test. Acute saline infusion test is performed using 2-liter normal saline IV infusion over 4 hours while the patient is recumbent. Plasma aldosterone level after saline infusion was found to be 12 nanogram per deciliter. We shifted the patient to spironolactone 50 mg once daily, and the follow-up visits revealed a dramatic response with controlled blood pressure readings less than 130/80. Indications for screening patients for primary aldosteronism include patients with hypokalemic hypertension not explainable by medications, patients with resistant hypertension, those requiring more than 3 antihypertensive medications, including a diuretic, and the blood pressure remains above 140/90, patients with an incidentally restricted adrenal mass, and patients with family history of hypertension. Screening methods for primary aldosteronism include aldosterone ratio, that is the best screening test at present, owing to its superiority over single measurements of aldosterone and renin activity, being independent of circadian and dietary induced changes. It is recommended to change medications to drugs that do not affect the RAS axis, In particular, beta blockers and aldosterone antagonists are known to strongly influence the ratio and need to be seized approximately 2 weeks for beta blockers and 4 weeks for aldosterone antagonists prior to screening for primary aldosteronism. An aldosterone to urine ratio of more than 30 is considered a positive screening test for primary aldosteronism. Thus, we need a confirmatory test. The first confirmatory test is acute saline infusion test. Patients can undergo this test on an outpatient basis, and this is the great advantage of this test. Patient doesn't need to be hospitalized. Infusion of 2 liters of isotonic saline over 4 hours with patients remaining recumbent. An incompletely suppressed aldosterone level after saline infusion confirms the diagnosis of primary aldosteronism with a threshold value of 5 nanogram per deciliter. Aldosterone after saline infusion was found to provide sensitivity of 100% and specificity of 97% for diagnosing primary aldosteronism. The second confirmatory test is the fludrocortisone suppression test that is the gold standard for diagnosis. It requires 4-day administration of synthetic mineralocorticoid fludrocortisone 0.1 milligram every 6 hours and associated with high sodium diet. Incompletely suppressed aldosterone levels above 6 nanogram per deciliter confirms the diagnosis. However, this test carries the risk of severe hypokalemia and hypertension and needs a 5-day hospital stay at least. Another confirmatory test is the oral sodium loading test. It consists of loading of oral salt over 3 days confirmed by urinary sodium excretion above 200 milliequilibrium, and on the 3rd day patients are required to collect 24 hours urine sample. A urinary aldosterone concentration of more than 12 milligram per 24 hours confirms the diagnosis, but with specificity around 91% and sensitivity 72%. My take-home message now is that primary aldosteronism is considered to be the most common form of endocrine hypertension, accounting for nearly 20% of cases of resistant hypertension. It should be suspected in cases of resistant hypertension, especially those associated with hypokalemia. Calcium channel blockers and alpha blockers should be used instead of RAS blockers and beta blockers for 2 weeks prior to testing for primary aldosteronism. Thank you.
شكرا دكتور محمد. You highlighted the importance for the screening of primary hyperaldosteronism. Now, I think you quite right nowadays because it is not uncommon actually, but
Yes,
we can just overpass it a little bit.
I have nearly 3 cases.
When should we screen? I mean, if the patient, you have a patient with resistant hypertension, as you just mentioned now, should we depend only on the low potassium level, or what do you think? What patient? Because the investigation of this sort of conditions is rather expensive a little bit,
Yes.
and is not common in most of the laboratories.
Yes.
Whom should we screen for those patients?
We shouldn't depend on hypokalemia per se. Hypokalemia is only present in nearly 40% of cases of primary aldosteronism. So we shouldn't depend on hypokalemia alone. We should take all the picture together. Primary aldosteronism is common middle-aged females. Those mostly will have other labs normal. Other investigations, I think, will be normal. Patients we can have a therapeutic trial with spironolactone 25 to 50 milligram according to guidelines, that will guide us to complete the investigations. In this patient, I suggested for my patient to complete the investigation to perform CT or MRI to search for renal masses, but the patient refused. She said to me, I am controlled now on a single drug and I don't want to proceed further for any invasive or non-invasive even investigations, and she refused. I think we have to put the whole picture together to proceed for investigations.
Any question from the floor? Dr. Azza, Dr. Wafa. Thank you very much.
Thank you.